Good afternoon, everyone. My name is CB Mamaril, and on behalf of the PHSR National Coordinating Center here at the University of Kentucky College of Public Health, I'd like to welcome everyone to today's webinar as part of our PHSR Research in Progress series. Today's webinar will be on exploring the cost and delivery of STI services by health departments in Georgia, a mixed methods approach. And before we get started, we remind everyone that today's presentation and speaker bios can be downloaded from the Files to a box at the top right corner of your screen. So in the interest of time, it is my privilege to introduce our presenters for today, beginning with Dr. Gulzar Shah, who is an associate professor and the associate dean for research at the Jiangping Zhu College of Public Health at Georgia Southern University. Dr. Shah currently serves as a senior associate editor of Frontiers in Public Health Services and Systems Research, and as a consulting editor also for the Journal of Public Health Management and Practice. His interdisciplinary training and multi-sector work experience spans over 20 years, with appointments in both academia and public health practice agencies, nationally and internationally. Dr. Shah's research interests include data improvement tools, practice-based PHSR, e-health, and public health informatics, public health finances, and maternal and child health. Dr. Shah is also a trained FAB site visitor. Our other presenter, Angie Peden, is the coordinator of the Office of Public Health Practice at the Jiangping Zhu College of Public Health at Georgia Southern University. Her duties include coordination of the Center for Public Health Practice and Research and for the Georgia Public Health Practice-Based Research Network. Ms. Peden focuses on connecting the College of Public Health with the Georgia Public Health Practice community and facilitating practice-based research and technical assistance. She also coordinates the Georgia FAB Learning Community, which is a group of public health practitioners working together to better understand the requirements for national public health accreditation. Ms. Peden's research focuses on accreditation and quality improvement. We are pleased to have with us our presenters for today. Gulzar and Angie, I turn it over to you.
Good afternoon, PHSSR family. Ms. Peden and I are going to be presenting our study. We have a strategy here. We're going to be doing some tag teaming, and so the strategy is that we'll have Ms. Peden start, and then we decided that whoever feels overwhelmed, we're going to tag team back to the other partner. So Angie, would you like to go ahead and start?
Thank you, Gulzar. First, I would like to thank everyone for having us here this afternoon. Thank you, CB, for the introduction. And before we get started, I'd like to state that this research was supported by a Quick Strike grant through the PHSR and PBRN National Coordinating Center, and also through a subcontract with the Florida PBRN. I'd also like to acknowledge the rest of our research team. Gulzar and myself were joined by Alicia Wright, Carmen Williams, and Aaron Jackson. And I would also like to thank our commentators that are joining us later, Dr. Bill Livingood and Zeroy Morris. So to keep with our time here, here's our outline. We're going to start with our background, then we're going to discuss the purpose, the methodology, and our findings, and hopefully have some time for some questions and answers. To start with our background, STIs are a major public health problem and source of disparities in Georgia and also the rest of the southeastern part of the country. Georgia has some of the highest national rates of gonorrhea, chlamydia, and syphilis. We rank 6th in gonorrheal infections, 13th in chlamydial infections, and 3rd in primary and secondary syphilis infections. And Georgia's overall STD rate was 703.9 per 100,000. So that just gives a little bit of background of why we felt that this study was important. Additionally, prevention and management of STDs are among those public health services consistently provided by local public health agencies. And this delivery continues to be an issue, a local public health issue. There's variation in the cost of STIs across the country, and we have seen that research elsewhere shows that there might be ways to reduce this cost. This is a map of Georgia and our public health districts. We have a unique public health system with 159 counties, and these are grouped into 18 different health districts, each containing anywhere from 1 to 16 counties. Each county has its own governing body in the form of a board of health, but each health district has leadership dedicated to uniting these counties in the district and offering quality public health services through shared shared services. So we do have a wide range of number of counties per district. Some of the smaller districts, as far as number of counties, are located in the Atlanta metro area, and they have anywhere between 1 and 3 counties. And then some of our more rural areas can have up to 16 counties. So the purpose of our study was to explore the ways to estimate the costs of delivering public health services based on qualitative information, and there's also a quantitative component from 8 counties within a Georgia Health District that we work very closely with. That's the Coastal Health District, and this district has both urban and rural counties. And our sub-aim was to identify and validate appropriate cost components for the STI program and identify sources of data for studying cost components. Also to examine the variation in the delivery system and characteristics, including the centralization of both IT and HR systems, and then additionally the responsiveness to the local community or local public health governance. Additionally, we wanted to allow for a comparative analysis and contrast between findings of our study and the Florida study, and I'll go more into that when we discuss the methods. So comparing the state's local public health delivery system characteristics, the differences between Georgia and Florida. So Florida is a centralized state where we are decentralized. Examining service provision and information systems because this will have a broader impact on policy and practice. So on to our methodology. For the qualitative piece of this study, an interview guide was developed by the research team, and this guide included 9 open-ended interview questions with specific probes that were used by all that were involved in the interviews. The key informants that were interviewed were identified by Coastal Health District leadership, and these included 8 county nurse managers, 2 site nurse supervisors, 2 district administrators, and then the district nursing director, STI director, women's health coordinator, and the Ryan White director. The team conducted 16 interviews, and these interviews ranged from 30 to 60 minutes. They were semi-structured. They were recorded, transcribed, and then verified. Data were coded and analyzed using the in vivo program. The interviews were iteratively coded and then recoded to maximize inter-coder consistency. Everyone on the research team was involved in this. Onto the quantitative portion of the study. Our study population here was all 159 counties, and a census design was used. So the counties were contacted and asked to identify county staff that specialized with specialized knowledge regarding both administrative and clinical STI protocols. A structured survey was used, excuse me, and this was developed and adapted from the Florida PBRN cost study. This survey was pilot tested by selected district STD and CDS managers. And then the final survey after the pilot test was distributed to district STD and CDS managers, district CDSs, and then also county nurse managers. the Qualtrics survey software was used to distribute the survey. After the initial 195 surveys were distributed, 2 follow-up emails were also sent. We had 177 surveys that were partially or completely answered with that was a 90.8% of response rate. And then the responses that we received represented 157 of Georgia's 159 counties. We ended up using 134 complete responses for the analysis, and this was due to the fact that our goal was to have one individual response from each county. When we did not reach that actual goal, we looked at the responses and found individual county-level responses from 108 county nurse managers. We analyzed those responses and selected district-level responses to represent as many additional counties as possible without duplicating responses. We've talked more about this, and we've discussed some other analysis options for the future, including possibly separately analyzing the county responses and then the district-level responses. And Gulzar is going to speak more about that when we examine the findings. We used SPSS 22 for data cleaning and analysis, and for this part, this is just the beginning. We have developed a main report with just based on descriptive analysis of the initial data for the quantitative section. And now I'm going to turn this over to Gulzar. Thank you.
Good afternoon, all. I've seen the attendee list go from 20 to 28, and that's exciting. That's exactly 40% increase between when we started and now, so it's exciting. I'm glad that people are not dropping but adding. So I'll be presenting the results from both qualitative and quantitative components. I will start with the qualitative component because that's the sequence in which the study was, two components of the study were conducted. And so as a reminder, the qualitative results are from a case study of the Coastal Health District, which consists of 8 counties, and it consists of 16 interviews. All right, so, well, these are some of the themes that emerged from our qualitative data. I'm not going to go into detail because you'll see the details later. So the first slide is about what are the, basically, what kind of services are provided. So, you know, prior to this study, since it's exploratory study, we had to do this exploratory study because we did not have information about what kind of services are provided, what kind of variations existed, and what are some of the mechanisms for the service provision. So the most common STI services provided in the Coastal Health District were, and the counties within the 8 counties within the Coastal Health District were screening and testing, outreach and education, treatment, partner notification, and the least common services were patient counseling, physical exams, providing information and education at health fairs, and lab tests. Okay, so services were provided by both county and district staff. So what kind of services were more common by, by county or the district staff? The majority of respondents indicated that the STI services for syphilis, chlamydia, and gonorrhea were provided by the county health departments, utilizing local boards of health staff. Many health departments mentioned that the STI services were provided by both the county and the district staff, or some services by county staff while others by the district. For example, outreach, screening, education, and partner notification are the services provided jointly, and in-house screening and treatment are done by the county staff. Okay, so basically, individuals who provide the STI services. STI screening was most commonly provided by county health department nurses. Although county nurses most commonly provided STI screenings, communicable disease specialists or CDSs were included in the conversation that some health departments when discussing the provision of STI services. So, such as outreach and community education, pre and post-test counseling, partner notification, etc. Not all of the county health districts worked with the CDSs or the communicable disease specialists. However, many of the health department nursing staff worked with the CDSs when the occasion permitted. But the nursing staff was the one that consistently provided the services in the clinical environment. Okay, so the next we talk about, we inquired about sources of referrals, like where do the referrals come from? So health departments received referrals from the district staff or district office, physician's office, other agencies, hospitals, and emergency departments. Okay, so what kind of systems or processes were involved for monitoring and reporting of STIs? So STI services were monitored and reported electronically by the county health departments using Mitchell and McCormick Visual Health Net or VHN system and the State Electronic Notifiable Disease Surveillance System called SENDS, which is the internal system which connects with the district. In some cases, data were sent and stored at the district administrative offices. Okay, so one of our main questions was about costs of STI services. And obviously, as economists or our economist advised us, we tried to inquire about the fixed and the variable cost components. So the fixed cost components included staff, which means how many FTIs of various kinds, labs for testing various STIs, and exams. Whereas the variable cost components, again, included staff in regards to salaries and fringe benefits, medical supplies, postage in mail notifications, travel to patients' residence, phone services to contact patients, printing for outreach, partner notification, and those kind of services were variable in cost. Okay, so how were basically data collected and what kind of data were collected? So the common method to track financial reporting mechanism was the cost component. For the cost component was the staff completing a task survey. So this, all staff involved in the provision of STI services had to complete a task survey every quarter to capture their duties and the time in 8-hour periods in 15 minutes increment. So that's the level of detail to which the data were collected. Types of data collected were cost of STI services and testing, number of patients with a specific STI, demographics and location of patients with the STIs, and so forth. Number of STI screening, number of STI patients seen by the nurses, and cost paid or not paid by each patient. All right, so individuals that were responsible for collecting the data included county nurse managers, TDSs, district staff, accounting department clerks and program directors. And the time periods these data are available for is daily, weekly, monthly, and quarterly. All right. So there were some administrative differences in provision of STI services between rural and urban counties. Not going to go into detail in the interest of time. Now, next I would be presenting the quantitative component results. So these are the results from our survey of all counties in Georgia. As you might imagine, we had many questions, kind of detailed. This was a detailed survey. And in the interest of time, we've presented some findings that appeared interesting to us. But other things were interesting, and they could have equally been picked. All right. And one more clarification. In the purpose of the study, we stated that the data would allow comparison with the Florida study. That is the finding. Those are the findings we are not presenting today. But the mention was made only for the purpose that in future, when we do more presentations and write manuscripts and compare our results, we will be combining the data sets from both Georgia and Florida to do the comparative analysis that my colleague Angie Peden mentioned. All right. So let's get started with the quantitative results. They are almost always easy to present. And okay, so here is the number of respondents. There were 108 county nurse managers and then 19 district STD or CDS managers, and there were others. Okay. So percent distribution of location of STD screening. Where does the STD screening takes place? In all the counties, in all county health district or departments, the STD screening took place. In addition, for about 5% of the counties mentioned that outreach clinics do screening, and 21% of the counties mentioned that screening happens elsewhere in addition to the county health department. Okay, now this is really busy graph. It might seem intimidating, but it is really very innocent because it only gives you two messages. It shows you the method for screening that is most prevalent. So urine aptima is the most prevalent method. And the second most prevalent method was for the screening of these STIs was the provider collected swabs. And you could see self-collected swabs and culture were rarely used methods. Okay, so average percent of type of staff that usually performed STD investigations. So in majority of the cases, health district staff, 54% of the health district health department staff performed the investigations, and 45% of the county health departments mentioned that they performed for their county the STD investigations. All right, so this slide it shows the average time that takes, and it's estimated time reported by the counties that it takes to do treatment verification. Now it looks really funny, and there is a reason. And that's why we've presented both means and median. So I would say let's forget about the means and use medians, because means represent two things. One is they represent variation that was there, which is good to see from standard deviation. But also, I think that maybe there were actually outliers that were based on some kind of misunderstanding, because this is verification per case. And there were some values that we did not drop at this case, but we will probably drop, that were really, really, truly outliers that need to be eliminated. So if you look at the median, 30, 30, 30 for private physicians, emergency departments, and hospitals, that is like half an hour that it takes, and that's very uniform. It's just surprising that it came down to 30.0 for all three different types of or places where the treatment verification occurs. Okay, so from whom did the county health department, for who did they provide partner notification to? So all clients diagnosed through the county health department and clinics or their outreach services. 38% mentioned those. Then the next biggest category was those who did not respond in our survey. And all positive STI results in county was mentioned by about 15.7%. Only STI positive prioritized for partner notification. So it's like what kind of parameters were used for partner notification. And 4.5% mentioned some other kind of parameters. Was there any priority population for providing partner notification? And 46% mentioned there was no priority population, and 46% of the, I'm talking about 46% of the respondents. You can also think of these as 46% of the counties because we used county as a unit of analysis. So sex workers were, so among those who responded, sex workers were number one priority in terms of percent of health departments mentioning that. High-risk zip code was the next, and migrant workers were the next. Okay, so what type of services are normally provided for follow-up and notification, partner notification and follow-up? As you could see, treatment at county health districts is the top. Counseling, risk education is the next or most frequently provided service for partner notification and follow-up. And re-interviewing was the least frequently provided service. Okay, so this slide shows you the percent of clients that were covered by some kind of insurance. Well, as you could see, 44% of the health departments or the county or the respondents actually mentioned that they had 0% or they did not respond to this question. 38% said that only 1 to 25% of their clients were covered by the insurance and so forth. And as you could see, there were 4% of health departments or the respondents that indicated 51 to 75% of their clients were covered, and 76 to 100% of clients were covered for about 7% of the counties. And that was pretty much it. So as it says, questions are guaranteed in life, but answers aren't. So please go ahead and ask. We'll see if we can answer some or all.
Thank you, Gulzar. Thank you, Angie. So before we get to the question and answer portion, we are pleased to have with us two commentators today. We will start off with Dr. William Livingood. Is he already online?
Yes, I am.
Okay. And I'd like to introduce both of them first. And so first off will be Dr. William Livingood, who's a senior research scientist for the University of Florida College of Medicine, Jacksonville Center for Health Equity and Quality Research. Dr. Livingood previously directed the Institute for Public Health Informatics and Research of the Duval County Health Department and was also clinical professor at the Jiangping Zhu College of Public Health at Georgia Southern University. Bill currently serves as the principal for NIH and RWJF funded research projects and has an extensive record as a research and university professor for over 35 years, and has served as also academic department chairperson for over 15 years and a tenured faculty member for over 25 years. Following Bill's commentary, we'll also have commentary from Soroyi Chandler Morris, who is the District Program Manager for the Coastal Health District, Georgia Department of Public Health, and has worked in public health for 17 years. Ms. Morris's responsibilities are to assure the development of long and short-term goals for the health agency and participate in operational planning, monitor and evaluate the effectiveness of services and programs, and support the development and administration of budgets, policies, and regulations based on activity reports, planning documents, and program plans and objectives. Ms. Morris is also currently a Doctor of Public Health candidate at the Jean Ping-Su College of Public Health at Georgia Southern University. So the two commentaries will follow each other one after the other. So we'll have first Bill and then followed by Soroyi. So turn it over to you, Bill.
Okay, thank you. Thank you, Gulzar and Angie, for the very clear presentation. And I guess my comments, first of all, that it was great that you were able to get this completed. I know it was a struggle to get some funding for this, and then to launch this and get it all done in a relatively short period of time. But your participation rate of over 90% was really pretty incredible, given all that. I guess my comments are more related to, well, first of all, maybe it might be good to provide a little bit of a context. This study was meant to, as Angie had previously mentioned, meant to be a comparison, to provide some data for a comparison between Florida and Georgia, with the idea that Florida is known as a fairly highly centralized state, and Georgia, because of its district structure, is centralized around the districts, and therefore it's not a highly centralized state local public health system. And so the idea was that some of the things that make for centralization are HR systems and a similar, a basically state-coordinated public health informatics system. And Florida has a highly centralized HR system and a highly centralized electronic information system, whereas Georgia's are fairly decentralized. So we're looking for a lot of potential for variation. Georgia also has more formal county health department governance structures also, which are not as evident in Florida. So, so there is the potential for a lot of variation, and there were a few things where there is a fair amount of consistency. The type of testing is all around the urine testing and taking of swabs, and that some of the other types of methods for testing are in the Georgia study were not used very extensively. It's kind of interesting also that there's a lot of variation in who does the testing and who does the reporting. I noticed that I think I got it clear that nurses are used pretty extensively for the screening, and that the communicable disease technicians are not used very extensively but are used for other parts of it. The one thing that is somewhat evident is that there's a lot of variation here, and it goes back to the nature of these cost studies, is that we could do a lot of time studies on these things, but the reality is there's some pretty big variations in Georgia, and these kind of complement pretty huge variations that are found in Florida. So it does seem like if there are better ways of doing things and more economical ways of doing things, that that there is a lot of opportunity, because there's a lot of variation and fairly great inconsistency in how these services are delivered. And the cost, for instance, for having a nurse provide services versus a disease investigation specialist, a technician to deliver the service is pretty great. I mean, and do you really need a nurse, for instance, to collect a urine test, or can it be done by a more of a technician level of person? So those are some of that kind of comes out a little bit. As Gulzar mentioned, we actually haven't done the kind of statistical analysis to compare in effect, the variation between Georgia and Florida. But looking at the data kind of overall, it does seem to be that both states are actually have a great deal of variability, and we'll have to hold off on our judgment on the analysis as to if there is that much variation. But it seems like what is surprising is that there is a fair amount of variation, and because of that, there's opportunity for doing cost studies that would actually involving interventions that could actually reduce the cost, using, for instance, like a quality improvement approach to and maybe a quality improvement approach to, in effect, adopt the cost-saving kinds of methods. So that's kind of some of my reactions. Be happy to comment more on specific things if there are some other questions or comments.
So Roy, you can go ahead and give your comments, please.
Hey, thank you. Good afternoon. First, I'd like to say thank you to Dr. Shah and to Angie, and thank you to the Office of Public Health Practice and to the Georgia Public Health PBRN for allowing our district to actually participate in this study. From a practice-based perspective, there are so many variables that actually impact our service delivery cost. In our district, for example, we are very much geographically challenged, and we have about 7 communicable disease specialist field staff, for example, that cover an 8-county region with a population of approximately 500,000. And just to put that into a little bit of a perspective, we have 2 communicable disease specialists who cover 3 counties each, leaving 4 staff to cover our 2 larger counties with a supervisor who kind of splits his time between administrative responsibilities as well as providing some backup field support. Added to that, we have nursing staff in the counties who have multiple responsibilities in addition to providing STI service support to those clients who report to their health department. So it's very important for us to understand service delivery in terms of unit cost so that we can actually better streamline our efforts as we offer support to our staff working in the field, as well as other related service support to those in the county. So we really look forward to the results of this study to help us to better inform our budgets. Also, as with all government agencies, funding is always a challenge, and particularly when you look at our STI service fees, they're very affordable, as you probably noted from this PowerPoint slide, and we also do not charge a fee to clients who actually report to the health department as case contacts. So we are consistently challenged with program expenses around providing those services to those clients, as well as the service cost associated with travel expenses to staff who travel in those rural counties in our district. So studies like this are very, very helpful to us, and the data is very valuable to us as we look to apply for grants to support and to supplement our existing program funding. So for these 2 reasons, we are very thankful and supportive of the research that has been done around this particular area in public health, and we really thank the public health research network for their support. And if there are any additional questions, I'd be happy to answer those.
Thank you, Saroy. Thank you, Bill. And we'd like to thank you for your commentaries, and also thank you to our presenters. So now we are opening the webinar to questions from the audience. And if you notice, this is the first time that we are sort of muting everyone on the phone due to in the past we wanted to avoid any inadvertent unmuting of phone lines. So the chat box that we have for everyone is now open, so please do type in your questions. You can direct it to either our presenters or to our commentators too as well, and we welcome most of the commentators to chime in too as well if there's a question that is sort of relevant to them as well. So I guess to get things started, as our attendees are starting to type their questions, I'd like to ask this question for Angie and Gulzar in terms of the data that you've collected, which is quite impressive given that you've collected data from over 90% of the county health departments in Georgia, and given also the uniqueness of the district level and county level, you could say, administrative structure of those health departments and those health districts. In moving forward in your analysis, are there plans to sort of disentangle or become more detailed in terms of determining the influence of how these costs are affected by either the district level characteristics or the county level characteristics of the health departments?
I will take that one on. So initially, the idea was that we will probably try to get almost every county that's possible, so all 159 counties, to have both the county staff and the district staff answer, so that we can separately analyze the district staff perspective as opposed to county staff perspective. Now, when we saw that although the response rate was high and we did get 130 representation from 134 counties, I think that we'll have to reduce our sample size a little bit in order to allow that. In other words, right now what we did was we took the county level staff responses, which was 108, I think, and then those counties for which we did not have a county level response, we took the district level respondents' responses and took that response to mean, although she responded on behalf of the counties covered in the district, to make it a county as a unit of analysis, we took the first county mentioned by each of the district staff. So there would be some kind of, we would need to clean the data in a way that we can do separation of district staff versus county staff. That we are working on, but we don't have a clear map yet or a clear plan yet.
I think that would be interesting. Of course, beyond the interest in the aggregate results, but being able to maybe pursue later on looking at the economies of scale and scope of these departments and how they affect the cost of these STI services as well. I think we've got a couple of questions now in the chat box, so let me start. There's a question from Marion about, for Dr. Shah, clarification. Are the counties in the coastal district all regularly collecting data on the details of their workday on a quarterly basis, or are you saying that this was a standard practice, or was that data collection that you all are overseeing?
Okay, I think that I can answer that question based on the interviews we conducted, but I think since we have Ms. Morris on, Troya, do you want to take it on, because you would have insiders in point of view. Troya, are you still here? Are you on mute?
Can you hear me now?
Yes.
Okay. Currently, staff are completing a task survey on a quarterly basis, but unfortunately, the information is very general. They are required to record in 15-minute increments whether or not they're working in a particular program area. So if they are a CDS worker, for example, they simply mark, for this 15 minutes, I am working as a CDS worker. It does not detail the work that they're doing, whether or not they're traveling, et cetera. So it's very general information, but it does capture specifically which program area they are working in, but it does not capture the details.
This is Bill Livingood. Let me, if I could just add a little bit of additional context. One of the things that we did with Florida when we were doing the survey was we had a great deal of data on cost. And when we compared the results of our, basically some analysis of things like STD rates, size of the county, and some other kind of more demographic variables, we did not find much of that to be, even though we found huge variations in the cost, we did not find those type of demographics to be that predictive of the cost. And what we found, and it was the subject of the Georgia survey as well as our survey, was that there was a lot of variation in what the counties did, including who delivered the service and some of the other factors. I mean, if they did verification, who they did it for, and who they collaborated with, and things like that seem to be much more relevant to explaining some of the variations in cost than things that you might have thought, like, there's literature on scale, economy of scale, and we didn't find that kind of relationship. What we're finding, and this is a little bit related